All right, wonderful. So guys, thanks for coming today. We're going to talk about food allergy testing and your role in food allergy testing results for positive food allergy. So thank you for coming today. I have a presentation. We are going to do about a 20-minute lecture with videos. Then we're going to have you role play a few different case scenarios that I have set up for you. All right, so the objectives for today. We're going to go over food label reading, just about a minute. It's not too involved for baked milk and baked egg allergies. Then we're going to go over the demonstration of a proper EpiPen technique, and that'll be part of our role play as well. We're going to discuss the differences between different food allergy syndromes like FPI and DOE. Raise your hand if you know FPIs or anything, if you know a little bit about them. Raise your hand if you know nothing about them. So you raise your hand for both. Okay, that works. Okay, and then we're going to talk about locating evidence-based resources for patients and parents if they're they've tested positive for food allergy. Okay, so let's go over the basics. So basically, food allergies are the body's response to the proteins found in foods. Nothing else. Your body's going to actually respond to the protein. So the 8 most common food allergies are eggs, wheat, shellfish like shrimp, soy, peanuts, cashews, and milk. Okay, did I say 8? I think I said about 8. All right, we're going to go over this a little bit later. About the food allergy syndromes, but let's watch this video quickly.
During an allergic reaction, the immune system responds to a normally harmless substance as if it were a threat. In some people, common foods such as milk, eggs, and peanuts can trigger such a reaction. So how does this work? If you have a food allergy, your immune system makes a type of antibody called immunoglobulin E, or IgE. This class of antibody binds to immune cells called mast cells and basophils that circulate throughout your body. When you are exposed to the food allergen, it attaches to the IgE antibodies. This binding signals the immune cells to release histamine and other chemicals that cause allergy symptoms, such as swelling of the lips, hives, and shortness of breath. Because mast cells and basophils rapidly release these chemicals, an allergic reaction typically occurs within 30 minutes after exposure. The most severe kind of reaction is called anaphylaxis, which can cause a sudden drop in blood pressure, trouble breathing, dizziness, and possibly death. People with food allergy and poorly controlled asthma are more susceptible to severe reactions. An anaphylactic episode must be treated with a hormone called epinephrine, which maintains blood pressure and opens up the airways. To deal with accidental exposure, people diagnosed with food allergy are prescribed a medical device called an autoinjector that delivers a single dose of epinephrine into the thigh muscle. Antihistamines alone are not an effective treatment for anaphylaxis. There is no cure for food allergy. The best way to manage the condition is to avoid the allergenic food, read food labels carefully, wash hands and household surfaces, and always carry an epinephrine autoinjector. If you are accidentally exposed to a food allergen, seek medical help immediately. The National Institute of Allergy and Infectious Diseases, or NIAID, conducts and supports research to better understand, prevent, and treat food allergy. In 2010, an expert panel sponsored by NIAID issued guidelines to assist healthcare professionals in diagnosing and managing the disease. These guidelines and a summary for patients, families, and caregivers can be found on the NIAID website.
All right, great. So that just went over kind of a general idea of food allergies and the mechanics and pathophysiology behind them. So common reactions for food allergies. Can anyone, without looking at this, name some food reactions?
Coughing.
Coughing. Anybody else? Vomiting.
Wheezing.
Wheezing. Hives. Okay, wonderful. There's also loss of consciousness, flush, abdominal cramping, and swelling of the face, tongue, or mouth as well. All right. So in order to diagnose food allergies, providers will look at the history of the patient. They'll do skin testing or skin prick testing. They're going to look at blood serum, and there's also food challenges, which are the gold standard, and which is why we do food challenges here, to see if the patient's really allergic to the food or they're not. It just happens to be some kind of coincidence. All right. So when the providers look at history, they're going to look at the causal food or foods, the quantity ingested, the time course of the reaction, and other factors like exercise or alcohol, and also reaction consistency. So if you have a patient that has, say, a Mars bar and it happens to have a peanut, the patient has a little bite of it, has a reaction, and then a couple months later, they don't have a reaction, maybe it's something else, it's not the peanut. So they're looking at the consistency. Okay, the skin prick testing is another thing we do in the clinic you already know about, so that'll help kind of test if the patient is positive or negative, but it goes along with the history and the serum. We're not just diagnosing based on the skin prick testing. One thing that I really liked, two things that I really liked when I was reading the research, that the wheal size, so the size of that bump on the skin, is not correlated to severity of the outcomes if the patient has that food. And then, so that's the opposite of what you would think, right? Like if their wheel's like 20 by 20, it looks huge, but maybe they're not going to react that way. And then that negative tests are 95% reliable. So if we get a negative skin prick test for cashew, that's 95% reliable that that patient is not allergic to cashew. All right, and then the last one is food elimination, or there's also food elimination diet. And what this does is the patient removes the food from their diet for 2 to 8 weeks. That way they don't build up any kind of tolerance. And they do daily symptom scoring as well, so they record the symptoms if they have any nausea or vomiting without the food. And then they'll do a food challenge to reintroduce the food, and that will help us determine if there's other symptoms that would correlate to a positive test. All right. I'd like to talk about allergic disorders as well. So I'll probably ask a few questions at the end of this lesson if you want to take notes. If you don't have a pen, I've got 2 here. Anybody? Allergic disorders, there's a few. There's oral allergy syndrome, eosinophilic gastroenterologies like EOE, FPIES, which is the dietary protein-induced enterocolitis syndrome. We just call it FPIES, so you'll see a patient come in with that FPIES diagnosis. You're not like, what is this? You'll have a little bit of background on it. And then dietary protein proctitis. So each of these are a little bit different in their mechanism. Different foods kind of induce this allergy. It happens in different parts of the body and at different ages as well. So we have oral allergy syndromes, and basically this is with fruits or vegetables cross-reacting with the pollens of like trees. And so the patient will eat raw fruits or vegetables, and because of that cross-reactivity, they'll have like mouth or lip swelling. And then there's rarely any kind of anaphylaxis or anything like that. Another one is eosinophilic gastroenterologies. These are IgE, cell-mediated. So that video earlier you saw, that was the mechanics of how this occurs in the body. Symptoms vary with this one. You're going to have dysphagia and pain in the esophagus, which is trouble swallowing. And then you will also have ascites, which is swelling in the abdomen. You'll have weight loss, obstruction in the gastrointestinal tract, and swelling and nausea. And this is persistent throughout the life. The treatment for this is food avoidance and corticosteroids. Do you guys know anyone with EOE or any of our patients?
One came in today.
One came in today. Okay, so you're kind of looking at, this is persistent, it's not going to go away, and this is kind of the treatment. Right. Another syndrome is FPIES. We have a few patients with this. They'll see the dietitian or GI, as well as allergy. This is non-IgE mediated, but you can have an IgE reactivity to the trigger food. It presents in infancy, and what you're going to see is 1 to 4 hours post ingestion of cow's milk, soy, rice, or oat. You're going to see vomiting, and then you'll see lethargy, poor growth, and diarrhea in these patients. It usually resolves over time, but re-exposure can cause hypotension, diarrhea, vomiting, dehydration, and eventually shock if it's not treated. And then our last one is dietary protein proctitis. This is mostly in infants and is due to the patient ingesting cow's milk or food through the mother's diet and breastfeeding. So the patient will have mucousy, bloody stools, and it's, like I said, it's in infants, and it's also eosinophilic as well. All right, let's talk more about food challenges, because we've been doing them a lot here, and I feel like people don't know as much about them. If a patient has symptoms, then they've failed their food challenge. If they have no symptoms, then they've passed. Potential risks of this are atopic dermatitis flares, so they'll get that rash, emotional distress for the patient, maybe they're vomiting or they're having an anaphylactic reaction, which is why we keep our emergency box out with EpiPens and Benadryl and Albuterol. All right. So go ahead and look at your papers here. Here's one for you, Kevin. There is food allergy information here, and this is mailed to the patients. Depending on what foods that they get at home or that they're being challenged to is what they have to bring in. So say you have a patient or a parent call in because they don't know what to expect, they should have been mailed this form. If they haven't been, you can kind of go through this list with them. So they can expect to stay 4 to 6 hours for the food challenge. So they need to bring entertainment, toys, books, tablets, whatever. They'll bring their EpiPen, they can bring water, and they're gonna bring the challenged food. So you'll see here, on the second and third pages are the challenged food ingredients. So if they're going to be challenged to beef, they'll bring in a cooked hamburger and condiments to put on the burger, as long as it's something they haven't had a reaction before. A common call we get is baked milk and baked egg challenges. I never know what to say, but this has a recipe right here for it. So if a patient's doing a baked milk or baked egg challenge, the parent will bring the muffin in, and there's a recipe right here for them to bring that in. And what that'll do is the patient will be exposed to the baked portion, so the proteins are broken down. And patients can sometimes tolerate that and sometimes not. All right, wonderful. And also you can ask the patients to eat 2 hours before. So a small breakfast, that way they're not super hungry when they get here as well. And also stopping antihistamines, like if they're getting skin tested. You always stop the Zyrtec or the Benadryl 5 to 7 days before the actual appointment. All right. So let's also go through patient education as well. Now the provider can go through this, but this is in the scope of nursing practice. So I feel like it's really important, like Catherine and Christy, if you end up working with an allergist, this is awesome. You could have a nurse visit for this or call or whatever. So the provider will give the patients food allergy action plans and an EpiPen administration guide. So when you guys are role playing, I'd like you to look at the sheet, especially the MAs. I think that's one of your role plays. So the two most commonly prescribed modes of epinephrine autoinjector are the AviQ and the EpiPen. So you can kind of pass these around. And then here are the directions on the top here regarding each of them. So the AviQ will actually talk to you and give you the directions. And so what you do is you hold it on the outside of the thigh if they're having anaphylaxis, and you count for 5 seconds. You don't have to take clothes off, you don't have to do the disinfecting. This is a life-saving medication. And then the same with the EpiPen, but you hold it for 3 seconds and count slowly as well. So we'll actually go through a video for this.
Practicing with the EpiPen training device can help ensure you, as well as your family and friends, know how to use the EpiPen autoinjector in the event of a severe allergic reaction. It's very important to only use your training device when practicing. Never use a real EpiPen to practice on yourself or others. The training device works the same as EpiPen, but without a needle or its medicine called epinephrine. The training device looks different from EpiPen. It's clearly labeled Trainer, and it's gray, while EpiPen is yellow, and EpiPen Junior is green. To use, grasp your EpiPen autoinjector with the orange tip pointing downward, blue to the sky. Remove the blue safety cap by pulling straight up. Do not bend or twist it. Orange to the thigh. Place the orange tip against the middle of your outer thigh. Swing and push the orange tip firmly into your mid-outer thigh until you hear a click, and hold on your thigh for 3 seconds to simulate drug delivery. Count slowly. 1, 2, 3. Practice as often as you need. Reset the training device by replacing the blue safety cap, placing the orange tip on a hard surface, and squeezing the sides of the orange tip as you push down. The training device is now ready to use again. The training device can be used to teach family and friends how to use EpiPen at the first sign or symptom of an allergic reaction in case you aren't able to get a free EpiPen training device. Or for more information about severe allergies and EpiPen, visit epipen.ca.
Awesome. That's also a really good video that you can share with patients if you're going through EpiPen training. I was talking to Dr. Wang, and she said that where she worked before, the nurses actually did the EpiPen training. I think the providers get pretty sick of explaining it over and over. Okay. But that's one thing in our scope of practice we can do. All right. So let's go back. We were under patient resources, and we were talking about the EpiPen, but also let's talk about the emergency anaphylactic action plan. Did everyone get a copy of this as well? This is really important. The provider can go over this. So in the event that the patient is accidentally exposed to the food allergen, this is like an action plan. So it gives the directions of what the patient or parent should do in this situation. So there's a step-by-step guide. If a patient has mild symptoms, say the itchy nose, itchy mouth, a few hives, or mild nausea or discomfort, then you're going to give them antihistamines. So that's Benadryl. That'll take about an hour to kick in or so. However, if there's symptoms for more than one system area, you're going to give EpiPen right away and then call 911. So even if the patient's having mild symptoms, still monitor them. If the symptoms get worse, give EpiPen. So it's like a cascade. So just assess and see how they do. Again, for severe symptoms from more than one area, shortness of breath, anything like that, EpiPen, call 911. and then they're good to go. So this may be given to schools. It'll definitely be given to the patients and the parents as well. All right, so the management of food allergies, reading food labels. I'll talk about this briefly because Dr. Moran didn't think it was super important. Baked milk and baked egg allergies, you're gonna read the food labels. So if it has milk or egg in like a processed food that's cooked, you wanna look at the first 3 ingredients. If it's not egg or milk, then the patient can get it because they go off of ingredient concentration. So the higher concentrations foods in that processed food are listed first, and then it goes down the list. All right, wonderful. And then, so other management is carefully selecting restaurants, avoiding cross-contamination like cutting boards and things like that. You can wear identification jewelry. Has anyone seen that? I have not.
Yes.
You have seen it? Cool. That's cool, especially for the little ones. Like, don't give my kid peanut. And then just teaching the patient and parent to recognize allergic symptoms, how to use the EpiPen, and calling 911. There's also a ton of general resources online for patients and parents. All right. We already went through that. So I think that's it for my presentation. I have some questions for you guys. Name 3 differences between proctitis and EOE and the other gastroenterologies. Go ahead.
EOE is lifelong.
Okay.
Weight loss and abdominal pain.
Okay. Anybody else?
Proctitis usually resolves.
Yeah, that's good. In infants? Anybody else? You remember? Did you take notes?
I heard it was mucusy bloody stools.
Okay, and that was for proctitis. Okay, so that's in infants if they have cow's milk or they're getting a food they're allergic to through their mother's breast milk. Okay, wonderful. So we are, we've been going on for a while now, so I'd like you guys to read your role plays. Take a minute or 2 to plan, so work with your partner, and then if we have time, we'll give demonstrations, okay?
Do you want to shut this off?
Thanks for coming.
Yes.
Yes, that's fine.